Okay, first of all, thanks Laura for hosting this forum. Thanks Niall for your presentation. Um, as you will notice in the next things that I'm going to say, there's quite some overlap with what Niall has already said, especially in terms of digital exclusion and inclusion and understanding local use context before you go and deploy mobile health applications. Now, I'm a second-year DPhil student in international development, so my perspective starts basically at questions of inequality before technology comes into the equation as a solution. I'm also looking at the broader area of health, but unlike Niall, I'm looking at the demand side, basically the potential users of health applications, whereas Niall is looking at the providers of health services. What I'm going to talk about is basically some of my research findings, or preliminary research findings, from qualitative research in Rajasthan in India and Gansu in China. To give you a bit of background, I started off in my PhD also considering the idea of evaluating an mHealth project, understanding, okay, what's the impact, do they actually deliver what they're supposed to do? But as I went through the literature and as I went through the projects, I realized that the narrative is usually constructed around very optimistic expectations and assumptions about what's actually going on. Now, I'm not trying to stereotype mHealth as one solid body of approaches, as Niall has quite good illustrated. There are also nuances in there. But in my view, there's a mainstream narrative which guides not just policymakers and those who propagate more mHealth and more use of mobile technologies, but it's also easily found in academia as well, because it's easy to excite people with mobile technologies, especially in areas that we consider resource-constrained in low- and middle-income countries. Now, one caveat before I continue, what I'm looking at on the end-user side would basically be the broader area of services and technologies that involve the end user and the end user's mobile phone. So we would be talking, for example, about hotlines that people can call from mobile phones to get medical advice from doctors and nurses. We are looking at SMS-based reminders, for example, to take medicine when it's due or to realize the doctor appointment. You might also be thinking about public health information, that you receive a message on your phone on how to stop smoking and so forth. So basically everything that involves the end user's phone. But anyway, so here are some quotes that I hope illustrate what I think is the mainstream narrative, or at least parts of the mainstream narrative that you often encounter in the area of mobile health. Now, the narrative goes something like this, and Niall has illustrated it to some extent already. We see that across the world, in high-income countries, but also in low- and middle-income countries, more and more people have mobile phones. Even in resource-constrained areas, or so-called resource-constrained areas, more and more people get mobile phones. India and China together now have more than 2 billion subscriptions, mobile phone subscriptions. So the technology is becoming ubiquitous, more or less ubiquitous. Everybody has a mobile phone. Now, at the same time, what we see is that there are persistent gaps, challenges in terms of accessing healthcare, health facilities, health personnel, and getting treatment in exactly those areas that experience this rapid surge of mobile technologies and mobile phone ownership. Now, why don't we do this? Why don't we use this technology that's already at people's fingertips? The infrastructure is already there. And why don't we just deliver the services through the mobile phones that people already have? We reduce costs in terms of delivering services. We increase access to services, and while we are revolutionizing healthcare all over the world. And I'm not exaggerating, this is actually some of the words that you can find here probably somewhere on the slide. Now, I would think that there are a number of assumptions inbuilt, and you would probably agree. And I mean, I'm obviously using the most dramatic narrative here, but more or less along these lines, it will be very easy for you to find similar stories. Now, some of the things that you will notice here is that this narrative, this approach, this very supply-driven approach, arguably, assumes that technology excites in the same way that it excites us. So everybody would be a keen user of new technology, of mobile phones, and derivative services that use mobile phones as a platform. We assume that many people, if not everyone, even in low and middle income countries, has a mobile phone nowadays. Even if it's not a smartphone, but at least probably every household, even in India and China, the places where I study, could be expected to have a mobile phone. right? Near ubiquitous ownership. Ubiquity of mobile phones is quite a common theme nowadays. But even if people don't have mobile phones, they can easily share them across households, within households, so that the positive effects of mobile health applications can easily be relayed to other people who don't have a mobile phone, right? Information is being diffused to other people, but people can also access others' neighbors' mobile phones in order to get access to the services that are being provided. So targeting is not an issue here. At the same time, we also assume that the mobile phone as a platform is neutral when we deliver services through it. So we don't necessarily assume that people change their behavior just because they have a mobile phone now. And we assume that the mobile phone is always adding value, or mobile health applications add value to what the mobile phone is doing, rather than undoing harms that the mobile phone brings about, for example. Similarly, we think that if there are gaps in healthcare access, then people have a demand for mHealth solutions, right? So people will take it up more or less necessarily. And ultimately, that will then have a nearly unambiguous positive effect on their access to healthcare. Why? Because we often see underlying the narrative a certain reasoning that is either transaction cost based or based on an information deficit model, the high level elements that Niall just illustrated. What it means is that with mobile phones, you reduce transaction costs of navigating the healthcare ecosystem and getting easier, cheaper access to doctors, nurses, or any kind of services that you look for. Or you don't have access to those services because you don't know enough, so you just provide more information, so everything will be better. It's very difficult to construct scenarios under these assumptions in which anyone would be a loser. So in the worst case, no one would use it, but no one would be worse off under this line of reasoning. So as a result, then, the inequities, by giving people easier access to health services, especially between rural and urban areas, between low and high income countries, inequities will decrease and boundaries will vanish, basically. Now, as you can probably figure out quite easily, I will give you some examples why this need not necessarily be the case. And then we go through the assumptions more or less one by one. Before I start, just some background on my case study. I went to Rajasthan in India and to Gansu in China to carry out qualitative research, which is the first part of my research before I do quantitative household survey data collection. I went to rural areas only, and I went to those places because they reflect a rather high adoption rate of mobile phones. So mobile phones are quite common. At the same time, they're very persistent healthcare challenges because they share a very hilly topography. Facilities are more or less well developed, but people have difficult access, especially the more remote the places get. So this is the context here. In the qualitative data, I have to caution it's not representative, but is geared towards a maximum variance sample, which means that I wanted to get out as much as possible, appreciating the variance of users. So I was also actively looking for people who don't have mobile phones. So I might overestimating that part a bit. But nevertheless, the point is to tease out what is the broad range of mobile phone uses, mobile phone adoption, and people's behavior in order to explore phenomena and then later test them. So at the moment, we are at the exploration stage of it. But be that as it may, in both cases, I see at least very high mobile phone adoption rates. In rural Rajasthan, 70% of the people had a mobile phone, even though I was actively looking for people who didn't have one. But as you can see, it's quite difficult. In China, in Gansu, there was even higher, 80+% had a mobile phone. Few people had smartphones, which probably shouldn't be surprising, given that it's resource-constrained areas that we're looking at. But by and large, you can see, okay, many people have a smartphone, and that probably many people have a mobile phone, but that probably shouldn't surprise you. But that's not the point. My point here is that if you guide mobile health applications and mobile health services just by the idea that people have mobile phones, you might be doing a mistake, for example, in terms of targeting. What do I mean by that? Well, unlike very widespread mobile phone ownership, you see a lot of differences in the way people use their mobile phones. To give you some numbers, between 70 and 80% of the revenue spent in rural areas on mobile phones, on how people use mobile phones, is on voice communication. There might be some 5% on text and 25 to 20% on mobile data. So voice is the dominant mode of interacting. It's not that people are keen users of text messaging. Mobile internet adoption is very low and mainly concentrated among younger people. In fact, you can mainly see a convergence between ownership and the use of the phone features that are available among rather young people, the tech-savvy young. So below the age of 25, people use the functions that the phone provides. But above that, and this holds for both India and China in my research here, above that, the divergence increases accordingly. So the older the people, the more the reliance on very basic features. So the phone is actually not the constraining factor here. It's the way how people engage with it. And even then, even if people use mobile phones, for example, for voice communication, it doesn't necessarily mean that they use the phone actively for that. They might just passively receiving phone calls, and I will illustrate it with a few quotes later. So they do not actively make calls, but they only receive them. If they want to make a call, they might give the phone to someone else to do it for them. So these are just some very basic illustrations that would make you reconsider, is there actually a value in providing further services through mobile phones? And actually in those cases, in those contexts, you have a couple of services that are being provided, value-added services from mobile phone providers, where you can subscribe to health information, text-based public health information in China, from China Mobile, supposedly reaching 700 million people. Or in Rajasthan, you have health hotlines that are free of charge, where people could, in theory, call doctors and nurses. But if you're a passive recipient, for example, of a phone call, it will be very difficult to take the next step and then call a health hotline. So unless you appreciate this local context first before you start designing applications, you will run into trouble, arguably. But similarly with sharing patterns, some people don't have mobile phones, and we appreciate that. But sharing isn't as easily as we might assume. Sharing takes place among very limited networks and only for very important purposes. Your house is on fire, your mother is sick, you need to call an ambulance, you need to call the police. This is about when sharing happens, or when lending occurs across households, but not necessarily otherwise. So you wouldn't necessarily expect that information is easily diffused through public health information that you provide to people's mobile phones, not even necessarily within the same household. Because even though we assume that also in South and Southeast Asia there are traditional sharing norms, people might not be as keen to share mobile phones even within household members. And in fact, it might lead to conflicts if they do so. For example, unwanted calls being received, which create struggles between husband and wife. So people might be very cautious what sort of information they give to others, even within the same unit. I might be running a little slow here. So let me just talk you to some examples, some of the responses that I've received. When it comes to using the phone features, and that was what I just illustrated, people might be rather passive, even though they have a mobile phone. So ownership doesn't tell you much. If, for example, a Rajasthani 45-year-old mobile phone owner tells you that, yeah, right, I use the phone, but only to pick up a call, really. I can press that OK button, and that's as far as I use it. If I want to make the call, I give the phone to my son, and he will dial, and then I use the phone, but nothing beyond that. Text messages are basically invisible to me, she says. Similarly, a married couple from Gansu telling me, the wife telling me, well, yes, I do calling, I make and receive calls. I also do some text messaging. This is about where it stops. I do not text message all the time, only for major events, celebrations. If there's a festival, then I send a text message. The husband then says, well, actually, the fewer functions the phone has, the better, because then it's not that complicated. And it's easier to use. So we might have very strong expectations about people's readiness to use more functions and to use smartphones, especially the higher age they are. And that might you actually then, again, reconsider, but that should be our target group if we have mHealth applications, right? The people who have hardest access to the services, which tend to be older people and economically more disadvantaged people. So how do we then reach them if their functions, if they're digitally more excluded, functionally excluded from what you could provide through mHealth? Similarly, sharing patterns, and I'm not trying to paint the bleakest picture possible. Also, people who don't have mobile phones can use can make use of them within the family. Here we have a group of older people, aged 55 to 60 in India, saying that, well, we can use the phone every time we want to make a call, our sons make the call for us. But again, it doesn't necessarily mean that they're keen users. They get the phone, talk on the phone, give the phone away. That's it. They don't want to engage more with the phone. Why? Because they see they appreciate their own financial and economic constraints, so they want to limit the engagement with it in order to prevent further money loss, for example, in case they press the wrong button. So there's a certain hesitancy in using the phone for mere economic reasons. So learning by doing might be constrained by the similar kind of reasoning. Also, the teaching part, how to learn new features with your own phone, has become one of the themes in my research. Younger people teaching older people, usually younger males teaching parents or grandparents, mostly parents because grandparents face even more constraints. But there are limits to the patience of both teachers and students in this regard. The son can teach the mother 2, 3, 4 times how to use a calculator, maybe 5 times, 6 times. It gets very frustrating for both parties, then they give up, and maybe the calculator isn't even used anymore. So there are more and more barriers the more and more you look into the local use contexts. And just starting with the assumption, okay, people have mobile phones, you might be brushing over all these very little details that actually influence quite a lot what you can actually do. But then also the mobile phone as a platform is not neutral, and especially when it comes to health. If you want to deliver a health application, you assume that people are ready to use whatever you want, whatever you provide to them through the mobile phone. But that might be too simplistic. In my research, I find that people use mobile phones for health under the condition that they A, can use the phone, and B, see a valid reason to do so in the health ecosystem, so that the health system is more or less responsive to doing so. Under these conditions, there can be some productive and useful use of the mobile phone for health already before you implement any sort of health mHealth application or service. For example, people negotiate access or coordinate access to the health system, hospitals. If, for example, you have an ambulance, arguably you could say this is an mHealth service. An ambulance can be called to bring you to the hospital. If this is not available, they can negotiate access to private transportation from family members, neighbors, taxis. This is something that they do by themselves. They don't need a specific application for that. Where the health system is responsive, where health providers are responsive, they can summon assistants to come to them, medical assistants. There can be a private doctor, it can be a village doctor, for example, in China. There wouldn't be necessarily a government doctor in India because they tend not to be responsive. This comes with cost, but it's one way of coping with the situation that they have. I come to the relevance of that in a second. People do make appointments already, even without an appointment reminder. If they have access to the health system and if they can access the doctor, then they might as well call the doctor beforehand to check whether the doctor is actually there and then go there and receive the treatment. If they are under treatment by family members, by a medical practitioner, if they are in hospitalized treatment, then they also use the mobile phone for assurance among each other within the social, private, personal networks. And lastly, more sophisticated users, both technically sophisticated but also more educated users, might use the mobile phone in order to discuss health in terms of exchanging advice on what to do, medical advice. Even more sophisticated users then would use the mobile phone, mobile internet to access health information and share it with others. You might suspect that this is probably for the younger users only. Now, if people do that already, then you might want to reconsider, okay, what then would be the added value of mHealth for those people who are not excluded, of course. Well, if you then deliver an mHealth application, say, as has been done in Rajasthan, a health hotline, then you might find, well, there's very little uptake of this. Why is that? Is it because we haven't advertised it sufficiently? Well, it might also be because people have already found a more or less solution to the problem by themselves using the platform, which is not neutral. And then what you do is basically render the solution, or that basically renders your solution redundant. It's been superseded before you actually implement it, because you don't understand the local context. It doesn't necessarily mean that the local use patterns are more efficient or more desirable from a medical standpoint. For example, if people get medical advice from a faith healer, who tells them to shower themselves with water for 10 days if they have malaria. But it's something that stands in direct competition with what you want to deliver. So if you don't understand the local use context, if you don't understand local health-seeking behavior before you try to develop a solution to people's alleged problems, you may run into problems, for example, A, in terms of targeting, increasing inequalities, what Naya mentioned already, or B, your service will be facing a lack of demand. In the interest of time and to have more discussion, I'm just skimming over the examples here. There are some people who say that they use the mobile phone either for themselves or ask other people for their mobile phone in order to get access, for example, in case of road accidents. People who don't have mobile phones also can get access to other people's, to neighbors' mobile phones in case of emergencies, to, for example, call family members to bring them to the hospital. So again, we're talking about functional exclusion, not exclusion in terms of adoption of mobile phones. So it's not the resources that are missing, but it's access or usage of it, of certain functions. But not everybody uses mobile phones for that matter. If they feel that they have found a solution without a mobile phone, then they wouldn't feel compelled to use it. This woman in Gansu, she's got medicine at home, and for her, this is usually the solution that she needs when she's sick. For her, access to a pharmacist is very easy. So all that she needs and all the demand that she has is only for more medicine, unless you educate her and train her otherwise. But by a purely supply-driven process, nothing would happen to her, presumably. And again, this is just an example of people summoning assistance from village doctors because they are responsive, and they know that they are responsive, so they will do it. If they call an ambulance, the ambulance doesn't come, they don't call the ambulance a second time. So if they understand that the problem can be solved with mobile phones, they use mobile phones and they use solutions and they develop solutions creatively. So they are not as passive as we might suspect. So in a nutshell, what I'm basically telling you is don't go by just mobile phone adoption and mobile phone ownership as the only indicator of developing or proposing more mHealth. It's not the whole story. So use patterns are much more diverse and people are much more creative. So if there's anything I would like you to take away is that start understanding the context first before you go in and propose solutions. Solutions are not developed at the desk. They're developed in the field. Which is basically all that I'm saying here in the last couple of slides. I'm also not saying that there's no role for mHealth to play at all. There's something that you could do if you understand the context, and this is just very illustrative here, not deeply thought through. But for example, taking into account the local context, the local use context, in Rajasthan, what you could do, just an example hypothetically, you could target younger users within a household. The household is a more stable unit than, for example, in Gansu, and make them household health activists. Give them a fancy new phone, tell them that they can keep them, install some health applications if you want, but also train them and tell them, okay, you can keep this phone if you also act as an agent for other household members in your family who can't use the phone as easily and as efficiently as you can, and then convey or relay the services to them as well whenever they have a problem. So you will be the agent. By this way, acknowledging the different kinds of use and focusing or targeting on those people who might be using the functions that you want to deliver most efficiently, you can also relay the functions to other people more effectively. But just an example. We can discuss this as well. So I also have a set of larger questions, but we can discuss them further. So I would stop here and thank you very much for your attention.